Good afternoon, everyone. I'd like to acknowledge the local custodians of land in which we're meeting on this afternoon and honour elders past, present and emerging. I'm Melissa Wilkinson from the Hunter New England Central Coast Primary Health Team. Welcome. We have Sarah Houlihan today here with us. Thank you for being with us, Sarah, from PCIO from the PHN. Welcome, Sarah. Just some little bit of housekeeping. We have a poll at the end of the session. I please ask you to please complete that. We are being recorded. It will be available in the Education Library, and also the survey poll, as I've mentioned, is at the end. This is how we're going to get our data to plan future events. So if you could please help us out by completing that. Amazing. All right, I'm going to hand over now to Sarah. Thanks, Sarah.
Thank you, Mel. Just pull the slides up there. So I too wish to acknowledge I'm on the Central Coast, so I'd like to acknowledge the Darkinjung people as the traditional custodians of the land I live on, and extend my respect to elders and any First Nations people who are joining us today. My name is Sarah. I'm a Primary Care Improvement Officer in the PHN Urban Team. I've been a primary care nurse for a bit over 20 years now, and I have a passion for preventative and proactive care. I encourage you to use the chat box throughout the session for any questions you might have. And as experts in your own practice, I would love you to share any ideas that you have around quality care plans for improved patient outcomes. So it's exciting to see so many of you joining us today as we move into living with COVID and resume planned and preventative care. I know your time is limited. Sorry, Mel, we'll just go back to slide 2, please.
Yes, we just had a little bit of a glitch there, but the start. There we go.
Great, thanks. I know your time's limited. I've tried to pack in as much information as we can in half an hour. And our main goal today is to think about ways that we can improve outcomes for our patients living with chronic disease. Knowing that chronic disease is much bigger than we could ever hope to cover in half an hour, if you are new to general practice or if you're keen to delve deeper into chronic disease management, I encourage you to explore the education provided by the organisations which are on slide 2. And that's APNA, Benchmark, and the CVC training. And much of that is partially or fully government funded to support you to upskill specifically for general practice. So we can go to slide 3, please, Mel. Thank you. So care planning can be known by many different names, and I'm sure you've probably heard them all in practice. Generally, they're interchangeable. Provided that your patient knows the term that you use and they're able to give informed consent for the process, it doesn't really matter what wording you choose to use. For the purposes of today, the broad term we'll use is care planning, but you might see some of these terms being used as well. Thanks, Mel. So while there's no set list of conditions that are eligible for chronic disease management, GPs are expected to use their clinical judgment in determining which patients require a planned approach to their care. The Department of Health and MBS use examples such as asthma, cardiovascular disease, diabetes, musculoskeletal conditions, and stroke, but they also acknowledge that chronic conditions occur across a wide spectrum of severity and in a broad range of circumstances. So assistance in preparing the plan can be provided by a health professional such as a registered or enrolled nurse, an Aboriginal or Torres Strait Islander health practitioner, or an Aboriginal health worker. However, the GP must review and confirm all assessments and arrangements and see the patient either in person or via video telehealth. Medicare states that non-clinical staff such as reception, practice manager, AINs or MPAs can assist with the logistics of the process. So that might be things like recalling the patients, making the appointments, updating demographic data. But obviously it's not appropriate for our non-clinical staff to be identifying health and care needs, or to be providing assessments on the patient. We need to remember that the chronic disease care planning process is not just a mechanism to provide Medicare rebates for allied health services. The items are designed to provide GPs with a structured way of managing the wide range of chronic medical conditions and assist them to plan and coordinate the care of their patients. GP management plans and team care arrangements are recommended to be reviewed every 6 months, but the MBS allows reviews as often as 3 months where it's clinically necessary. New plans are recommended to be done every 2 years, but they can be completed after 12 months if it's clinically appropriate. Thanks, Mel. Just to the slide before, please, Mel. So when we're preparing a GP management plan, we must explain to the patient the steps involved in preparing the plan. We must record their consent, add a copy of the written plan to the patient's medical records, and offer a copy of the plan to the patient. The care plan or the GP management plan should address all of the patient's health needs. It should include the patient's goals and the who, where, and how of that all of their health needs will be managed. It's important that actions for the patient are included in plans to give the patient ownership of their health and to set realistic self-management strategies. There also must be arrangements to review the plan throughout the year. Slide 6, thanks, Mel. Oh, we're on it, thank you. So when it comes to team care arrangements, we basically need everything in the list for a GP management plan, plus documented collaboration with at least 2 other providers. So collaboration before billing a team care arrangement can be a fairly common oversight and something that we know GPs have been audited for, especially if they're consistently billing a 721 and a 723 on the same day before they've received collaboration from their other providers. So when we talk about collaboration, the provider that is being referred to should be aware of the individual needs of that patient. So whether they're an existing care provider or they're taking on someone new and have reviewed the care plan. The provider should specify exactly what treatment they are going to provide for this patient. It's not enough to have a blanket agreement. You must have you must have a list of exactly what the provider is going to provide. For example, a podiatrist, rather than saying foot care, they will specify if they're going to be, for example, doing nail care or management of skin, sensory and circulation checks, fitting orthotics, education around footwear, that sort of thing. Once the GP has received and included the proposed treatment from at least 2 other providers, then the 723 can be billed. If you have any questions around billing or eligibility, I encourage you to check out the link that is in this slide. The slides will be available along with the recording on the PHN Education Library, because all of the questions that you could ever possibly wonder about GP management plans and team care arrangements are all in there, including things around referrals and collaboration and who can contribute and that sort of thing. So it's slide 9, thank you, Mel. Beautiful. So why does it matter to you whether a care plan meets minimum requirements or if it provides a basis of quality care? The most obvious, I guess, is that if we're going to spend time on something, we want it to be worthwhile. As clinicians, we want to make a difference for our patients wherever they are at on their health journey. And most importantly, we want to choose an approach where we are not doing things to our patients or for our patients, but with them as partners in their healthcare. Slide 10, thanks, Mel. Thank you. So as I mentioned earlier, care plans need to include all of the patient's health needs. I often hear the term diabetic care plan, but really, even if that's the template that you start with, every patient with diabetes is going to have different goals and treatments depending on what's most important to them, their comorbidities, and their current health status. It's important to remember that we are planning care for the patient, not for a condition. Slide 11, thanks, Mel. Thank you. So the MBS items for chronic disease management specify that we must include actions for the patient to take. So why is this important? We recognise that the patient is the expert when it comes to their life and their goals. We recognise that health is far greater than just the physical. We want patients to identify concerns with their own health and to seek help early. And we reinforce the importance of self-management as shared responsibility. We also talk about proactively planning care and follow up with things we know they're going to need throughout the year, like scripts, referrals, reviews, and follow-ups. And this meets the Medicare expectation that care planning can reduce the need for ad hoc visits related to chronic disease and includes the patient in planning, so they're less likely to need urgent care at short notice. So slide 12, thanks, Mel. Thank you. So I've got a scenario for you here. Anne Smith has recently joined your practice as her GP has retired. On receiving her file transfer, this is what you find as her care plan. It looks a little bit like a health summary, doesn't it? While technically this plan does tick the boxes for MBS, it really doesn't provide any insight into the actual needs of the patient. The goals are vague, the treatment expectations of other providers is non-specific, and it doesn't help team members understand what treatment will be provided. Looking at Anne's active conditions and medication lists, she clearly has some pretty complex health issues, so this version of a care plan for her really isn't going to serve anyone well, least of all the patient. And slide 13, thanks, Mel. Now, I know there's a lot of text on here. Bear with me, you're not expected to read it all. It's just an example. So thankfully, a few weeks later, Anne's now eligible for a GP management plan and team care arrangement with you. This is going to be a comprehensive plan because she has tricky issues. This scenario is based on a real patient and is a replica of their real plan. So whilst Medicare only requires a minimum of 2 other providers, in a situation like this where multiple providers are already involved, it helps everyone in the team to know who's doing what so that nothing gets missed. It really helps too to consider where relevant things like nutritional status and falls risk, walking aids, transport, informal care, medication management, all that sort of thing, so that all members of the team know who the right person is to contact if they've got any questions or concerns to provide the best continuity of care. So you can see where that quality comes in to improve their outcomes if we know who we're meant to talk to and about what. Thanks, Mel. So why would a practice invest in the time required to develop a quality care plan? So management understand that proactive care of patients with chronic and complex needs means less ad hoc visits, less requests for appointments at short notice, less last minute script and referral requests, and less stress. Planned care even means that management can predict what their rostering needs are going to be in 3 to 6 months from now. GPs understand that while their nurse is relationship building, their health coaching and goal setting with the patient, the GP is freed up to be able to see more patients. They're confident that the patient is being empowered to self-manage their health in conjunction with their care team. Nurses are building professional rapport with their long-term patients, and a key feature of why many of us moved into GP land. The nurse is empowered to use their clinical skills to assess, support, and coordinate the patient needs. And most importantly, patients feel supported and empowered as a partner in their own health. They understand that their health team will not do things to them or for them, but with them as equal members of the team. A quality and comprehensive plan also helps to paint the picture of the patient's overall needs to save them having to tell their story over and over. Next slide, thanks, Val. Yep. So chronic disease is one of the main factors behind the gap in life expectancy between Aboriginal and Torres Strait Islander people and non-Indigenous Australians. When we talk about closing the gap, this is right up there with things that we need to be addressing. So to enable us to provide culturally appropriate care and quality chronic disease management, we need to know who our First Nations people are. We use the correct language. We consider whether care plans are going to be appropriate for our First Nations people with chronic and complex health issues. We offer them to be registered for closing the gap for their scripts, and we're offering them the annual 715 health assessment. If you have any questions around chronic disease management for First Nations people, I would encourage you to check out the PHN website, where we have a whole section on First Nations health and contact details for our First Nations health team. You can also find on Services Australia. This was only released in March this year, I think. So, and it's a whole small module around Indigenous health education, around care planning for our Indigenous patients. So the hot topic we're getting lots of questions about lately is often the diabetes cycle of care and where that now fits into care planning if we're not co-billing the 2517 with care plan item numbers. So it's important for us to remember that billing does not determine best practice. We absolutely can and should aim to meet the requirements of the diabetes cycle of care over the course of each year and for GPs to be paid for the care that they are providing. Now, there's a lot of text here. This is not intended to be prescriptive at all. But maybe this map of chronic disease management over the course of 12 months might inspire you to consider how you will continue to incorporate the annual cycle of care into your plans. And then all of these topics are links which you can access through the slides on the PHN Education Library. If you want to learn more about the complementary services to care planning and how you can use these for your patients to improve the quality of the care that they're receiving for chronic disease. And then when we look at the tools to assist you with care planning, there are lots of different programs out there, and they can all assist in different ways and each have their pros and cons, and often they have a cost attached to them. I've included these ones here because these are already available to your practice and they are completely free. So up the top in the middle, we've Top Bar, which is a point of care tool and shows all kinds of information, but for the purposes of today, is suggestions around eligibility for care planning and follow-up visits, and also, anything relating to chronic disease management. In the bottom left, we've got the PenCat or Cat4, which can be used to identify your cohorts and individual patients with certain conditions or who are on certain medications and the services they've received or may be eligible for. And then on the right, we've got there's some examples from a LUMOS report, and that's at the New South Wales Ministry of Health Data Linkage Program, which provides insight into your patient cohort engagement with health services outside your practice. So the extracts I've particularly chosen to include here are relating, of course, to chronic disease management. given that they look at, you know, unplanned hospitalisation, ED triage categories, access to GP care before and after hospitalisation, their main diagnosis in hospital, and any additional diagnoses managed whilst in hospital. If any of these programs are of interest to you and you don't currently have access to them, please reach out to your primary care improvement officer. We can absolutely help you to get these. And then finally, with International Nurses Day tomorrow, the theme for this year is just so fitting around the topic of chronic disease management, as investing in our nurses and giving them a voice to lead is investing in health. It's probably safe to say that none of us got into nursing out of a deep love for paperwork, but when we start viewing our care planning process as a way of working with our patients, getting them excited and involved about what their future could look like, and helping them to access the services that they need, we really start to see improvements in their health outcomes. So I hope our nurses and colleagues will feel empowered about our voice to lead and the difference that we can make in people's lives through quality care planning. And I wish you a happy International Nurses Day for tomorrow. Thank you everyone for your time today. I know that it's a really busy time in practice, and I do appreciate you taking the time to be with us. As Mel said at the start, please use the evaluation at the end to let us know what you want to learn more about, to give us feedback, and because that's how we can make sure that we're continuing to meet your education needs. So, thank you.
Thanks so much, Sarah. And sorry everyone about the technical issues. The slideshow totally had a mind of itself, and I actually had to hold the cursor down to try and hold the frame. It just kept going forward. So that hasn't happened before. So we'll have to look into that. There is a couple of questions that have come through. I'm just going to untoggle the screen to get that up for you. So is it a chronic health condition or two for a care plan? Is it one or two chronic health conditions for a care plan?
There only has to be a minimum of one, but obviously it depends on the condition. So if you've got someone who has, you know, very well controlled, say asthma, so something really quite common, the GP would be looking at the clinical relevance of using a care plan. It might be appropriate, it might not, depending on the needs of that patient. Whereas a patient, say with diabetes, obviously we know that they've got lots of coordination required. So yeah, but the minimum is one condition, which is or has been consistent for 6 months or more.
Great, thank you. And there's one more. So is the GP MP generally completed the same day as the TCA, or at a separate day?
Not normally. Now there will be exceptions to that. Obviously, if you've got all of your allied health in the centre, or if you've got the allied health provider that you're referring to and they are on site and you know have had a chat with them, or if you've phoned up and had a talk to them about what the patient's needs are and they've said, oh, this is how I can contribute, and you've added that into the plan, then that meets the requirements for billing. If you're sending off an email or a fax or a sent referral saying, you know, please see the attached care plan, have a look, let us know how you're going to contribute, then obviously you can't be billing that until you receive their feedback, because you need to know what they're going to be providing.
Okay. Well, thanks, Sarah. That's all the questions that have come through. Thank you so much. I think I've got a good workout today holding that screen, goodness. And thank you everyone for being here with us today. I really appreciate it. The poll will pop up at the end and there will be a copy of it into the education library as well. So thank you, and thank you, Sarah. Have a lovely afternoon, everybody.
Okay, thank you. Thanks, Mel.